Good afternoon, everyone.
Afternoon.
So the good afternoon, everyone, started with our top speaker from today, Dr. Bob Blum. So for those of you that don't know Bob, he is the past chair of our esteemed department and a wonderful colleague and friend. But one of the things that, Bob, you taught us very early on at seminars was that you would say good morning or good afternoon. And if you didn't get a response that you liked, you did it again. So let's try it one more time, including those who are online. You can add to the chat. Good afternoon, everyone.
Good afternoon.
Bob, you taught us well, so many things. But today, we're in a department where we emphasize life course perspectives. And in a sense, we're doing that today as we take stock of advances in adolescent health, because we have multiple generations of experts in adolescent health who are here to share with us some of their recent findings. So I've introduced you just very briefly, and they'll tell you more about what they do, to Dr. Bob Blum, who's, again, a wonderful colleague and friend and past chair in the department, who was really, along with Kristin, Mmari, and Carolyn Moreau, the leads of the Global Early Adolescent Study that you'll hear more about. A recent graduate of the department, the esteemed Dr. Sam Beckwith. And as we were walking, I was walking over to seminar with some of our doctoral students. I said, we should grab some of our recent alums who live in proximity, to the greater Baltimore, Philly, DC area, and have them meet with some of our doctoral students to assure you that there is life after dissertation. And then also joining us today is Dr. Kristin Mmari, who many of you know well, is one of our faculty leads in adolescent health. So without further ado, I'll turn it over to you, Bob, who I think are kicking us off. So please join me in a warm welcome.
Thanks. Well, it's great to be back. Let me just say a couple of words about my two colleagues who are presenting with me today. Cynthia introduced Kristin, and many of you do know her. I have been a colleague of Kristin's for God knows how long, 25 years, 30 years. So and one of us simply doesn't look that old. I began to know and work with Kristin when we were both at the University of Minnesota. And then in 2004, 2005, somewhere around there, we together relocated with our families here to Baltimore. And we have worked really closely ever since. And then Sam Beckwith, in the educational process, both for students and for faculty, there's an alpha and an omega. There's a beginning and an end. Sam is the omega for me. He was the last of the doctoral advisees who I had, and have had the opportunity over the last, 5 years or so to work closely together. What we're going to be presenting today is work that began in 2022. And I'll talk a little bit more about that. And both Sam and Kristin will be reporting out more specifically some of that work. "30 years ago, the International Conference on Population and Development, which is also known as the Cairo Report, was held. And it was a transformative event. Now, I would say that the Gates Institute and the biannual meeting that has been held on family planning and reproductive health, followed on to the international conference, and was convened and supported by the Gates Foundation, primarily because our political structure in the United States changed. And in the late 1990s and early 2000s, it was risky at a global level for the UN to convene another population conference. And so the Gates Foundation picked up the torch. But the International Conference on Population and Development did a number of major things that have had profound impact. In my field, in adolescent health and development, one of the things that it did is it set a standard for engaging adolescents. And it said for the first time at a global level, young people matter. And we need to pay much more attention to adolescents. Secondly, and I would say profoundly, that conference put forward a different lens and a different framework on adolescence and on reproductive health. It shifted the orientation from population control. And some of you are too young to remember that population control was the focus for population health. And it was the major orientation that not only this department had when it talked about population sciences, but it was the global lens. And it shifted it from population to control to empowerment. 15 years later, in 2010, WHO and HRP, the shorter name is the Human Reproductive Health Program, but its title goes on for 3 pages, so I won't even take time to try to say what HRP stands for. But they convened an expert panel on adolescence, and I had the opportunity and the honor to be part of that panel. And it said that the work in human reproduction and health has to begin before young people become of reproductive age, that it has to start with young adolescents. And it was really the first time that young adolescents were on the global agenda. And it also reinforced a rights-based approach rather than a control-based approach to reproductive health. It said that to be effective, you have to understand the contexts in the lives of young people. And so reproductive health is not a standalone venture, but it is intertwined with social, political, economic, educational, and environmental contexts in which young people live. And that seems like a no-brainer today. But we have a long way to go, in fact, to actually operationalize that. And the report that came out of that expert panel said that we need to understand not just what works, but we need to start investing in understanding how it works, what today we call implementation science. So That's a bit of background. In 2022, WHO and HRP decided that it would be advantageous to take stock of what has been learned in adolescent health since the conference expert panel in 2010. And to do that, sort of this massive venture, I collaborated as a co-lead with a colleague of mine, Chandramouli at WHO, to begin what has been called the stock-taking process in adolescent health. Well, the field is huge, like any field, when you define it by age. And so we had to begin to narrow it down. We had to begin to focus it. And we convened an international advisory board who made recommendations to focus our work in 5 areas. 1, what are the trends in adolescent health? Has anything gotten better? Has anything gotten worse because of the global efforts in this field? Second, what impacts do youth policies have? You know, there was this sort of prevailing notion that if there were a law or there would be a policy, things would be better. But the question was, did things get better? Did these policies make a difference? The third was to look at the research on risk and protective factors in the lives of young people, and what have we learned? Fourth, there was a growing body of research and literature in gender norm change. And our work here in the Global Early Adolescence Study was one piece of this much broader picture. The fifth was innovations and priorities in adolescent research. So the advisory board set out these 5 areas. We solicited input from folks around the world and convened via Zoom focus groups, 90-minute focus groups in each of those 5 areas to understand what, quote, the field, people who are policymakers, researchers, program NGO leaders, thought were the most pressing issues. We commissioned a series of papers. Each paper had co-authors from the Global South as well as the Global North. And we then convened in the summer of 23 a meeting of experts to review the preliminary papers and to begin to develop a plan. This work resulted in what was published and released last week, actually this week, on Monday, at the United Nations, in a special supplement of the Journal of Adolescent Health. So that is what the work has been over the past 2 years. Sam Beckwith will speak to what have we learned in terms of trends, what's been positive and negative. And he'll be followed by Kristin. Mmari, who'll talk about gender norm change, and particularly the evidence of impact evaluations and what have we learned there. And again, that has been a focus of our work in the Global Early Adolescence Study. We've been exceptionally fortunate to have both colleagues within this department and across the school and the university who have been partners and colleagues. Ellen McKenzie, the dean, co-authored the lead commentary for the supplement. And so let me turn it over to Sam, who will talk about trends in adolescent health.
Well, thank you, Bob, for that introduction. And as he said, the paper I'll be speaking on is Trends in Adolescent Health, Successes and Challenges from 2010 to the present. And I had the really distinct pleasure of working on this with Bob and with Chandramouli as well. So let's start off with a little stage setting and think about why it's so important to consider trends in adolescent health. Well, the adolescent period runs from age 10 to age 19, and it's a time of really significant and even challenging transitions. So not only are you physically developing, you step into or you get thrown into new social roles, you're facing new expectations, you're tasked with constructing a new sense of self, really, and these tasks are really tough. And for those of us who work within a life course framework, we know that a healthy and stable adolescence is really the key to beginning adulthood on the right foot. We know that starting around age 10, gender becomes increasingly salient in the lives of young people all around the world. Young people entering this age see others begin to treat them more differently around this time. Girls might be expected to do more housework, to take care of their siblings, while boys might be hearing about how they'll have to leave school soon and begin to take care of the family. So there's a real increasing salience of gender. During the adolescent period, because of the internal transitions that adolescents are experiencing, stability, external stability and support from institutions and adults is really important. But we live in really unstable times. Many adolescents around the world have had their lives upended by conflict, drought, political instability, or other upheaval. And so it's important to consider trends in the context of the broader, global experiences that adolescents have. Also, the adolescent period is important to consider because it's a very large age cohort. There's about 1.3 billion adolescents alive today, making up 1 in every 6 people in just this 10-year period. And in some regions, it's over 1 in 5. And finally, adolescents are an increasingly diverse cohort, not only geographically, but we know that more adolescents than ever are publicly sharing their LGBTQ plus identities because of decades of transition in pursuit of economic or educational opportunity or migration due to avoidance of conflict or other areas of instability. Adolescents are also growing up in more heterogeneous communities than ever. So it's a diverse cohort, they have diverse experiences, and we will try to reflect some of that in our conversation about trends because they are not experienced uniformly. So really briefly, our approach to studying trends in adolescent health was a pretty straightforward narrative review. We considered international data sources, meta-analyses, and systematic reviews, as well as individual reports, to gather information on how adolescent experiences have changed over roughly the past decade and a half. So we started the review by identifying specific key topics and outcomes that we wanted to consider, spanning a variety of domains to reflect the multidimensional nature of adolescent health. And we also wanted to consider outcomes that were affected across ecological levels. So you'll see we'll mostly discuss individual health outcomes, but we can't neglect the influence of the family, the school, or macro level effects. So our major aims with this were to describe global trends in adolescent health since 2010, but also to provide important context on those trends. And finally, as I said, consider how trends may vary or how gains have been realized evenly or unevenly during this period. So I'm just going to dive in with the first outcome, which is under the domain of nutrition, and this is iron deficiency anemia. So with regard to anemia, which in adolescents can lead to cognitive and physical development issues, among other health concerns, there's been very little progress since 2010. So it's still a very prevalent disease affecting about a quarter of adolescents around the world, somewhat higher in girls than in boys. In some regions, this rate is much higher. In West and Central Africa, for instance, the prevalence of anemia is estimated at 50% of adolescent girls currently. And so while there have been some very slight decreases in the prevalence as a proportion of adolescents, the overall disease burden today is higher than it has been in past decades because of the increasing population of adolescents. And on the right-hand side, you can see the distribution of anemia prevalence around the world. The prevalence of overweight and obesity in adolescents is also increasing. So while anemia, which can reflect undernutrition, is prevalent but stable, these outcomes are increasing steadily and at a particularly high rate in lower middle income countries. So the graph on the right shows trends in child and adolescent obesity from 1990 to 2022. So this is bigger in our scope and population and time, but this mostly goes to show that the increases in adolescent obesity are not taking place in a vacuum. And we've seen some success in reducing underweight or thinness, but not nearly at the same magnitude as these increases. So just to sum up, we've seen essentially no progress in anemia, and there's regional and by income level disparities that persist for that outcome. And overweight and obesity has been increasing, and we see high country level variation and also by income level. We considered a number of sexual and reproductive health outcomes, which I'll present on this slide. And unlike for adolescent nutritional outcomes, for several of these, we have seen really notable progress over recent years, often continuing initiatives that have been in progress for a few decades. So with regard to HIV, since 2010, the incidence of new infections for those under the age of 15, for those under the age of 15 has increased by about, decreased by about 60%. From over 300,000 new infections per year to about 130,000. And this reduction is really dramatically outpacing reductions we've seen in the population of adults. So we consider this a huge success. Older adolescents also had notable decreases, but they were smaller than that 60% number. We should also note that older adolescent girls still have a higher incidence rate than boys by about 70%. And projections do estimate that HIV incidence among young adults will drop by at least 30% in most of the world between 2010 and 2030. So we should highlight, though, that the most unevenness here is within countries, as we said, by gender, but also by other aspects of marginalization that can affect your access to HIV preventing resources. In terms of other STIs, though, most are increasing among adolescents globally. The story here is very different from HIV because we do not have a massive global effort to combat non-HIV STIs at present. So rates really do vary substantially across countries, but trend success that the incidence of syphilis, chlamydia, trichomoniasis, and genital herpes are all becoming more common in adolescence. And adolescence remains a life stage that is at particularly high risk of HIV for STIs. So just using the United States as an example, of the 20 million new sexually transmitted infections that take place every year, about 10 million of those are among the 15 to 24-year age group. There are about 31 countries where female genital mutilation or cutting has historically been concentrated. In these countries at present, it's experienced by about 1 in 3 adolescent girls, which is substantially lower than the 1 in 2 that it was a few decades ago. So overall, we really do have a striking decrease, which has been mostly widespread, but there are some areas where there's been little observable change going back even so far as 30 years. With regard to child marriage, about 1 in 5 girls around the world will get married before age 18, which is a several percentage point drop since 2010. Some regions have really made remarkable progress. So we should highlight South Asia, where the prevalence of child marriage was roughly cut in half from about 50% to about 25% from 2012 to 2022. So that means in just 10 years, we saw a really remarkable decrease. But in other regions, progress has been slow. In Latin America, the prevalence of child marriage has been stuck in about the low 20% range for more than a decade. And it's also concentrating because we see much faster declines in child marriage among those from wealthier backgrounds. So it's becoming increasingly concentrated among girls from poorer backgrounds. And finally, adolescent childbearing has been decreasing since well before 2010, actually, and that trend has continued since then. Today, fewer than 1 in 3 adolescents will become a parent while still a teenager. But as the United Nations has noted, the pace of decline has been slow, and actually declines in overall fertility have at times outpaced declines in adolescent childbearing. This is also, like many outcomes, another where we recognize regional disparities. And within countries, those who experience social marginalization are more likely to begin childbearing during adolescence. Mental health issues have been, among adolescents, have been the focus of much discussion in recent years, and for very good reason. So while children's mental health has remained pretty stable, internalizing problems such as depression and anxiety are becoming far more common among adolescents, and we see an especially strong trend among girls. For boys, it is present, but to a lesser extent. Overall, one study estimated that between the first and second decades of the 2000s, 14% more adolescents were experiencing depressive symptoms than previously. And while suicide mortality does not appear to be decreasing globally, the proportion of adolescents who experience suicidal ideation is non-ignorable in the mid-teens. On the right-hand side, we see a graph of anxiety incidence rates by age. And this is kind of hard to see. I know it's very small, but I just want to point out 2 things, which is number one, the early adolescent 10 to 14 year age range is when the incidence rate of anxiety is highest. And second, that the incidence rate of anxiety in 2019 was higher than that of 2010. So young adolescents have always been burdened, disproportionately burdened by this disease, and this trend is worsening, not improving. International data are also showing that adolescents are lonelier than ever. And in fact, in just the 6 years from 2012 to 2018, the proportion of adolescents across 37 countries who were feeling lonely almost doubled to about 31%. And in fact, only one of those countries had decreases in loneliness, and that was South Korea. All others, which included many countries in English-speaking regions, Latin America, Orthodox Europe, and East and Southeast Asia, had increases. And so you can see, as you can see on the left, this is also a very new trend. And prior to 2012, loneliness was actually stable for boys and girls. In terms of economic and educational opportunity, school enrollment has been increasing for children and adolescents since the establishment of the Millennium Development Goals in 2000. And by 2021, the number of secondary school-age adolescents who were not enrolled had decreased by 30% to about 195 million. And meanwhile, gross enrollment rates had increased over the 2010s for boys and girls alike. And so we can see that by 2020, in low and middle income countries, about 3 in 4 adolescents were enrolled in school. There have also been commensurate increases in educational expectations, although these are studied less systematically. For instance, a survey of young adolescents living in low-income countries, low-income areas of 5 countries, found that among all sites surveyed, at least 70% of them expected that they would complete an undergraduate education at least. And educational expectations are higher among girls than boys pretty consistently. But despite gains on the education front, we see that adolescent girls and young women are more likely than their male counterparts not to be in education, employment, or training, or NEET. In some regions, the ratio of such disconnection exceeds 2 to 1, favoring boys. Young women are expected to, and they do, take on more domestic and care duties than young men, and this can be a barrier to work. But such experiences are not universal, and they do vary quite a bit by region. And finally, relative to young men, young women who are working are more likely to be in informal work arrangements, which can be tenuous and lacking protection. So some of you might be thinking, how can we talk about trends but not discuss the COVID-19 pandemic? Well, it was clearly a formative experience for today's adolescents. And we know that the burdens of the pandemic fell most heavily on those who were already experiencing economic, social, or political marginalization. The mental health trends that we discussed a minute ago were certainly exacerbated for some adolescents, but for others who had higher family connectedness and higher social support, they were less affected. And we know that many were already feeling lonely at the turn of the decade, and that took yet another hit due to the pandemic social isolation. Food insecurity was not uncommon during the early days of the pandemic, especially. And likewise, there's indication that not only were some adolescents during that time reassessing their educational expectations, usually reassessing them lower, but also in areas where schools closed, not all students returned to school after reopening. And finally, while COVID-19 was a global pandemic with life-altering effects for many adolescents, for some, it was simply one more in a host of challenges and even crises that they had to navigate. And so the salience of the pandemic was not uniform across all adolescents. So to sum up a large volume of information that I went through pretty quickly, we have seen some successes, especially in the domain of sexual and reproductive health and in education. But on other issues, we've been basically stagnant or seen real trends toward worsening outcomes. And what divides the two? Well, it's clear that where we've had successes, those have also been the target of long haul and coordinated global investments. And where programs have not had such global attention and backing, we've been met with challenges. And finally, even in instances where there have been global improvements, the gains realized by adolescents have not been experienced by all, and disparities by gender, by geography, by poverty, and other areas of marginalization really do remain. In some cases, they've been exacerbated, and we have to consider them really seriously as we move forward. So thank you very much. I'm going to pass it to Kristin to talk about intervention.
So hello, everyone, and thank you, Sam. So as Sam mentioned, I'm going to be talking about gender transformative interventions, which really builds on the work that we've done here at the Global Early Adolescent Study. But also, as I will tell you, there's been a proliferation of gender transformative interventions. Let's see here. I think I skipped ahead. Well, here we go. There was just one slide. No worries. It's like, that wasn't part of it. Okay, so as I was just saying, there has been this huge increase just in the last decade of programs that target gender as a key pathway to improving the health trajectories of adolescents. And this is really propagated by two related themes. And the first is that this increasing recognition that we have to focus on 10 to 14-year-olds. They have this, we call it the window of opportunity, where their gender attitudes, their formation about their self, their identity is all happening in this stage. And so this represents a really great opportunity to intervene. Secondly, there's been this growing recognition that gender is a critical social determinant of health. It actually affects adolescents' exposures to different risks and behaviors. And so we need to think about how we can address gender for health trajectories among adolescents. The other thing that's happened is that our work here at the Global Early Adolescent Study, in addition, there's another huge global program called GAGE. What is it? Gender and Adolescence Global Evidence, I think it stands for. Thank you. Yeah. Both of these studies have shown that adolescents as young as 10 years old have already formed attitudes about gender. And so we can research this. So, oops, I'm having trouble with slides here. So what do we know? So again, the stock taking thing was about, okay, where have we gone? Where are we going? There have been already several reviews of gender transformative interventions. And this is not only just looking at gender transformative interventions in general, but if we look at child marriage, if we look at female genital mutilation, all of those programs that have tried to prevent them, we have seen that those that use a gender transformative approach are generally more successful. So there's enough evidence that's been gathered that we know that this is a promising approach. But what we don't know is, and what we have seen with the Global Early Adolescent Study, is that a lot of these programs have been plagued by implementation challenges. So we don't really know the success really because of all these implementation challenges. So my authors, I should mention Callie Simon from Save the Children, who's been very active, a great partner with us in the Global Early Adolescent Study, but also involved in a number of programs. And then Ravi Verma of ICRW in India has been involved in gender transformative programs for decades. But both acknowledge that, yes, these are programs that are plagued with implementation challenges. So let's look at them. Let's try to address it. So that's what we decided to focus on with this paper. So again, the key objectives were really to focus on what are the key facilitators and what are the key barriers to gender transformative interventions among adolescents in regards to implementation. And then can we use those findings to recommend future research and programming that can really guide the next generation of gender transformative interventions. So we did a literature review. I'm not going to go through all of this. I got really familiar with COVID-ins for the first time. So we focused as much as we could on 10 to 14, but they weren't the only age group, but they had to be in the sample at least. And we focused again, the programs had to have at least a gender transformative intervention approach, some approach. And they were published after 2010. We used a number of these search terms I'm not going to go over. But in addition to the literature, we also gathered gray literature from organizations that we knew were doing this kind of work. We also looked at references lists from the articles that were pulled. And then we also spoke with experts who also recommended further articles. So again, this is hard to read, but just to show that we started off with about 707 articles that were pulled from the literature. We also got 73 from the gray literature and other sources. After going through all of this analysis, we basically arrived at 59 articles that were in our scoping review. So how we did this is we decided to focus not only on articles that were intervention, some type of evaluation, but also, as I mentioned, there were quite a few reviews that were done. So we also gathered those, as well as what we would call thought pieces, just articles about these types of approaches. So they were all included. If an article was an intervention piece, we had a big spreadsheet, which we listed the type of program, the name of the implementer, et cetera. And then if an article was more of a thought piece, more textual, we analyzed that like a qualitative textual data, and we tried to identify themes. So from all of this work, 3 key themes did emerge. And that was the notion of how do we tailor interventions for different genders. Then there was the need about including multi-level approaches as well as multi-sectors. These themes then, once they did emerge, we did have additional group meetings with our experts to confirm, is there anything else about this that we should look at? And then in addition, we did 5 key informant interviews with folks that were in the field to also gather additional information from each of these themes. So just to kind of go through these very briefly, the first is tailoring interventions for different genders. And when I mean different genders, since we were focused on low and middle income contexts, this is really looking at boys versus girls in most of these contexts. But what we found was that the majority of these interventions, while they may have included both boys and girls, boys were often ignored in many cases, or they didn't feel it was for them because they thought that this is really, we're supposed to be thinking about the girls. And it makes sense because girls are most disadvantaged, but it really placed the onus of these programs for these long deeply entrenched norms on boys. They had to fix these problems, they felt. And in fact, we actually had a youth conference in Bali, and we had a youth advisory board meeting there, and we asked them about our own findings, because we were finding the same thing in the global early adolescent study. And we asked, why are we seeing this? And boys said, well, this is a girl problem, so we don't feel like we need to be involved. And so that is echoed in a lot of these findings, is that when we look at especially the effectiveness, we see that mostly girls are benefiting more compared to boys. So given this, though, there's a debate, though, on how best to involve boys in these programs. So some believe that if we're going to be really targeting gender equality, we should just have boys only groups, because they may feel more comfortable if we do that. And there has been success in that. So typically these types of programs have soccer clubs, or they go through sports and they have some type of role model to talk about gender norms. But then there's others that say, no, if we're going to really talk about gender, it has to be among all genders. And so those types of approaches, mostly called gender synchronization approaches, really try to think of gender as a relational topic, where each boys and girls talk about basically the responses of these norms on their health with each other. And then there's still those that say, no, girls are the most at disadvantage. We still need to focus all our efforts on that. So there's a debate within the field still that goes on of how best to do this. But the important thing that we realize, though, is that, well, wait a minute. So many of these interventions have a uniform approach where they have the same curriculum for boys and girls. And even if they have these synchronized approaches, they just separate the boys and girls. They talk about the same topic, and then they come back. But what one review described is that, well, wait a minute, are we doing this in the right way? Because boys and girls are impacted from these gender norms differently. But why are we having the same approaches? Why are we talking about the same things? And so there's this notion that maybe we should tailor these approaches much more differently between the two genders, at least in low and middle income countries. And one review actually found that looking across, boys may be benefiting more from approaches that are more community-based and more peer-based, whereas girls may be learning more in an educational setting more. So thinking about that. So how do we go from here? Well, just some of the best practice that we pulled. These gender synchronization approaches do offer a lot more potential. And that's where we really need to engage with all genders to really focus on how each gender is being impacted, and then thinking about different unique ways of approaching those. Other reviews have found using peer mentors, community leaders, role models are really important. For boys, this may be teachers or sports models or sport role figures in the sports world may be really effective, but thinking about that in the community, who are those? Multi-component approaches are really important. And I think this has to do with how boys and girls may be learning differently, but there has been reviews that have found we are more likely to see successes for both boys and girls if we have these multiple components. So mass media, combining it with community campaigns. And then finally, we need to have multi-sessions that last at least 4 to 6 months. And that's simply because we need trust to be developed. We need, learning takes a while. These are deeply entrenched norms. And so if we're going to be talking about them, we need time to have this kind of seep through adolescents' brains. Okay, finally, the other thing, and I'm going to combine these, is really looking at multi-level and multi-sectoral approaches. We're dealing with gender norms, right? This is in every single aspect, institutionalized systems everywhere. But so many of these interventions only focus on the adolescents. And then they're supposed to go home and talk to their families, their peers, where they're getting all the other different gender messages. So there's this huge need. If we are going to really address gender equality, we have to think about multi-level and multi-sector approaches. But this is so difficult. In fact, every review that we got said, oh, we need this to be multi-level. We need this to be multi-sectoral. But then you try to find evidence for, okay, great. Well, where does this exist? It's a lot more difficult. So there's very limited evidence on how to do this well. So that leaves us with a very limited knowledge on, okay, if we are going to, let's say, address parents, how much exposure? Do we have to do 4 to 6 sessions with them, is that enough? We don't know. What do we approach them with? How do they become interested in this? Gender is a very sensitive topic, especially with adults. Also with sectors, if we're talking about typically health sectors is very involved in this, same with education, but that's not only where the gender norms exist. We have to think about other sectors as well. And that becomes challenging because you need resources, you need coordination, and those things are very, very difficult to achieve. And especially when we're talking about scaling up and sustaining these things. So we didn't find a whole lot of very successful programs. DREAMS is I'm sure some of you have heard of the DREAMS initiative, which was this big, enormous project that was multi-sectoral and multi-level, but it hasn't shown an overwhelming level of success, right? Because of a lot of these implementation challenges. So that really leaves us with a call to action of we need to find evidence on how to do this well. And we also, if we are going to be doing these among adolescents, we can't just measure change among adolescents themselves. We have to, if we are targeting parents, for example, we have to measure change among them, among teachers. But again, that takes resources. So what did we learn as far as from the limited amount of evidence that we did pull from? Well, first of all, we have to prioritize which levels and which sectors. And a lot of that depends on what are we trying to change. One of the things we learned in the Global Early Adolescent Study is that the norms are, if we're going to address norms, it's not going to have the same effect for all outcomes, behavior. So you have to identify what is it that we're really thinking about changing. And then you think about, well, what are and I don't mean to use jargon words, but we call it reference groups. But basically what I mean when I talk about reference groups is these are the individuals or organizations that can put sanctions on an adolescent if they do a behavior that's not the norm, right, so to speak. So we have to identify who are those reference groups, what are those organizations, and they're going to have the most influence. Increase attention on parents and caregivers. So that is one of the things that we've learned, especially in this age group. Parents and caregivers are still one of the most dominant transmitters of gender norms. And so we have to think about ways of including them. We have to think about also other system strengthening approaches. So if adolescents are going to the healthcare provider, there's norms that are being transmitted there. How can we get them involved? So we have looked at some of these programs that have used kind of a systems approach, and the DREAMS initiative, for example, where they integrated services. That may be a way because we're already getting adolescents in the door there. We can try to evolve there. Another important thing that we learned is that we have to identify from the very beginning, even before we start really implementing, what is the pathway for institutionalization? I can't even say that word. Institutionalization, there we go, and scale up. Where do we go? And one of the things that we learned is that if there's an existing platform that we can use, go there. So if we are going to be focusing on parents, what are some of the ways that parents are already getting together? Is there a PTA? What are those groups? Leverage those, and those have been more successful. So in terms of where we go from here then, one of the things too is to figure out where we do see successes among boys and girls. What are those key ingredients? Can we identify them? And so part of that though is understanding, again, from a life course perspective, if we think about an adolescent's life, they have different roles throughout their life. Their brothers, their sisters, wives, husbands, all of that, when they go through those trajectories, gender norms and the impact of them change. So how can we utilize that? We also have to think about the intersectionality approach, which is, I know, a big buzzword, but it's so important because gender interacts with a variety of different factors. But again, so many of these programs just focus on adolescent group as a universal group. We have to think about different tailoring approaches for different subgroups. And then we have to gather more evidence. So a lot of this is more research, right? But how much, what groups and what types of approaches are best for parents and these other systems? What's the best level of duration? Do we have to do it the same time period for adolescents? Is 6 months? Is it 1 month? We don't know any of that. We need to figure this out. And then finally, all of this is going to take funding. But so much of this is constrained by funders that are only allowing 2 years or 3 years of funding. And it's very difficult, especially when we're talking about gender equality, to be able to see, well, are we going to see these changes? In fact, it was in one of our sites in Kinshasa where it took 5 waves of data collection to finally see some changes in some of our outcomes. So it begs donors especially to allow for a more long-term longitudinal funding to see changes. And that, I will give it over to Bob.
Let me just take a moment to summarize a few things that I take away from both Sam and Kristin's presentations. When I think about the advances in the trends in adolescent health, one of the things that strikes me is that where there has been concerted effort, investment, and work at a global level, we see positive change. We see that in female genital mutilation. We see that in education. We see that in the reduction of the gender gap in education. And where there hasn't been investments, we either see no change or things getting worse. So there's this bizarre and inappropriate belief that these problems are just too big. We can't really touch them. And that's simply not true. The evidence shows we can, and we can shift the needle in very important ways around these issues. A second thing that I think about are the words that we use. In an international context, when you're doing multicultural work, terms matter. So one term that we talk and use with the belief that it has common meaning is gender transformative interventions. But in a lot of places, that translates to surgery, gender norm change, gender change. What are we talking about? And how do we make what we're talking about crystal clear to a global community? And it's complicated, but it's also very, very important to pay attention to that. A third thing that I take away, and I will tell you, I heard this as recently as 2 days ago at the United Nations, where we presented some of this work, is that sexual and reproductive health is girls. It's girls, it's not boys. And that orientation, that this is all about girls, leaves out half the world. And it will never change unless boys are an equal part of that equation, that programming is equal for boys as it is for girls. In much of the world, boys are doing worse than girls. They're doing worse. They're more likely to leave school. They're less likely after COVID to go back to school because their perceived notion of manhood is that I'm going to go out and work. So we have to think about these issues of young people together and not segregate out for girls or boys. And I think that was one of the messages, at least, that I take away from what Kristin was saying. We don't have time to talk about all of the other papers, but there are a few things embedded in those other papers that I would just want to very briefly mention. Here at Hopkins, we learn about research and we do research. But what is research? And what is the pathways that we have, or what are the pathways that we have to knowledge and learning? We have, by and far, a quantifiable or qualitative kind of approach. But in much of the world, knowledge is transmitted through storytelling. Where does storytelling fit in to our ways of knowledge and knowing? Where are other cultural lenses part of our ways of doing research? And there is a call in these papers for shifting the way that we know, not eliminating the qualitative and quantitative approaches, but augmenting and adding to it. Who's our audience? Is it the journal? Is it another publication? Is it our peer researchers? Who's our audience in the work that we do? And then how do you reach that audience? Is it young people themselves? Is it policymakers? Is it program specialists? How do you get knowledge used? And I think that's fundamentally our task and our challenge. Just a quick comment about policies, because looking at policies that make a difference is one of the papers in one of the areas of work which we did. And fundamentally, policies that provide concrete, specific, and I'll give you a couple of examples, specific benefits for young people have impacts. Eliminating fees for uniforms, as they have done in Kenya, has had a significant impact on enrollment and school completion. Eliminating fees for schooling itself, another example. Conditional cash transfer programs that are linked with educational programs that support families, and particularly mothers, as in the landmark work in Bangladesh, have impacts. We know concrete things that make a difference. We also know concrete things that make absolutely no difference or worse. And I'll give you but one example, and that is here in the United States, in Tennessee. They decided it would be a really good idea that for kids who dropped out of school before completing high school, they would be denied the ability to get a driver's license. One could argue, well, yeah, sure, that's a benefit, a driver's license. But what does that mean? Well, the translation of that is if you're poor, you'll not get to work. That's what it translates to, because you have no way to get there. That's a problem. And that's a problem here in Baltimore. That's a problem elsewhere. But a policy that may seem good isn't necessarily good. So we know a fair amount, hardly everything, but a fair amount about what makes a difference in programming, in policies and programs. I think that the challenge for us is how do you take what is known and implement it, evaluate it, study its impacts, and use that to improve outcomes. I think I'll stop here. Let's open it. We have a few minutes for comments and questions. And Sam and Kristin, maybe come up and join me here. And thank you. Let's open it for comments.
Hi, thank you, Sam, for your presentation. One of the questions that I had was, you mentioned some of the gender differences in specific health outcomes, and I wonder how gender norms regarding healthcare seeking and actually getting tested for some of these outcomes affected your results, and how you would address that in the future.
Yeah, no, that's a great point. And gender norms related to healthcare access, we can consider norms that are result in restrictions of boys and men's seeking of healthcare, as it's not seen like a masculine thing to do. There are also gender norms related restrictions to healthcare seeking that impact girls, maybe through different pathways related to, for instance, shaming of certain behaviors or things like that. And so it's absolutely something that is relevant in all of these. We kind of need, and we need more specific studies that drill down on where the norm falls in the pathway to make a big broad statement, but it's something that really needs to be considered. I think it's an important lens.
Kristin, did you want to add?
I mean, yeah, a lot of these programs are trying to figure this out because of the masculinity norms about boys have to be tough, therefore they're not going to go seek services. But if you think about some of these outcomes, and particularly mental health, I mean, that is a huge area where we're trying to figure out, well, how can we get boys to visit a mental health counselor, given the extent of what these problems are rising. So programs are targeting that, but again, it's very difficult. So we have to think about, I think going back to what I was talking about, multi-sectoral, how do we link services with school education and other things in the community as well.
Quick question for to start. I'm wondering how you think about, you were talking about separation of girls and boys.
Yeah.
How do you think about being inclusive to queer, trans, and other gender sensitive teens and adolescents, and whether thinking about that inclusivity might also be a route for solving some of these problems of integrating versus separating.
Great question. I'm glad you brought that up. So we have to think about the context first. The context drives where we can talk about that, because in many of the contexts that we work in, we can't even mention that because adolescents will be very harmed. So that's first and foremost what we have to think about. But in the sites where we can, in fact, we have colleagues in Belgium that actually looked at gender diversity. They just published a paper on that. So where we can, we're looking at that, and they have actually looked at a lot of these. I would encourage you to look at it. They just published it like a few weeks ago on gender diversity. In Baltimore, we hope that we can also start looking at that. But we haven't been able to because of the sites where we're working at. So that's why it's very hard. And I have to say the most of the interventions that we looked at, because we targeted low and middle income contexts, I don't think I saw a single intervention that looked at that. So we're very limited on how we can respond. I hope that's going to change, but that's where we are right now.
We have time to take one more question. I saw hands up over there. Yes.
Hi, thank you so much. I look forward to reading the papers. My question was about how social media, drug use, and explicit online content may have featured in some of the work that you guys have done.
And want to start anywhere in particular? I can just say, I think with social media, where it seems, and this is just one of the topics you raised, it's been discussed a lot in the context of adolescent loneliness. But we really need more work to unpack what exactly the relationship is, because there's a very suspicious trend in the coinciding of loneliness and when social media use really ramped up. But when we study it with a really particular eye towards the effect of social media, the effects are pretty pretty small directly, and there are some benefits to moderate use of social media. So it's complicated, but it is something that's a consideration. I'll let both of you hop in. But
No, I'd leave it at that. I think we need to wrap up. I would just mention that the journal that came out this week, the Journal of Adolescent Health, is an open access journal. You can simply Google the October 24 supplement of the journal, and it'll come up. All of the papers are available, all of the commentaries are available there. And we would welcome your review of it, and any feedback you would have would also be warmly welcome. Thank you very much.
And if you didn't get the chance to ask the question, because I know there was some online too, just feel free to reach out to us by email and we can hopefully answer by then.